thanks for joining us. I'm your host, Raquel Faria. I am an internal medicine consultant at the Centro Hospitalar Universitário de Santo António in Porto. Today, I'm joined again by Professors Ricard Cervera and David Isenberg from the Lupus Academy Steering Committee. Between them, they will be providing expert insights from selected presentations at the SLE Road 2024 Congress held in Bruges in March 2024. David, Ricard, welcome back, and thank you so much for joining us today. Before starting the discussion about the data presented at the Congress, I'd like to know what was your global insight of the meeting, David?
Well, the first thought that I had was I was just very happy for the two main organizers who, as you may know, had organized for this meeting to take place in March 2020.
Yes.
And at about 4 days' notice, they had to cancel it, and they'd done several years of preparation. I mean, having organized one of these meetings, I'm sure Ricard have the same feeling. It's so much work. It must have been heartbreaking for them to have lost that opportunity. So my number one sense was I was just happy for them that it could be organized. And it was lovely, actually. Bruges is a lovely town, and it was very well organized. And I liked the split or you had a choice between one clinical session and one basic science session, which was nice. Nice town, nice atmosphere, nice to see old friends again. I thoroughly enjoyed myself.
Ricard, what is your global feeling about the Congress?
I fully agree with David. I am more than happy because of the great success that certainly deserved the two main organizers, Natalie and Fred, after the cancellation in 2020 due to the COVID pandemic. We wanted to have this great meeting, and it was certainly great. I am also very happy to meet in this, let's say, medium-sized meeting. I think it's the ideal meeting point for all the lupologists. We have time to attend the different presentations, also time to meet each other, to talk, to discuss, and also at the end of the day, to have fun anyway. So great meeting.
So let's move to the data presented at the Congress. And this European Lupus Congress had several invited speakers from all over the world. There were 48 oral communications and 171 posters. If you go through all the abstracts, there is a very balanced thematic between patient-related outcomes, improving patients' education, understanding disease burden in SLE, tools to measure SLE activity, new and revised biomarkers in specific points of SLE involvement, and post-hoc analysis from clinical trials, and also real-world data of treatments. Some SLE data was presented from the COVID survey. It was presented in the Congress. And over 1,200 patients with SLE entered this survey. It used the Patient-Reported Outcomes Measurement Information System, the PROMIS, and it assessed not only COVID-19 data, but also several other demographic and comorbidities data. And one of the presentation that was derived from the COVID survey looked at the prevalence of comorbidity, multimorbidity, and mental health disorders, and their association with the patient's reported outcomes among the survey participants. It was interesting to see lower patient-reported outcome scores for both physical and mental health were associated with increasing complexity of comorbidity, regardless of age and disease duration even. Moreover, the patients that were on steroids had increased multimorbidity, whereas patients on hydroxychloroquine were associated with lower complexity of the comorbidity. It may look like not a surprise, David, but looking at this data, what is your critical analysis? And how do you think that this data presentation could change our clinical practice?
So I think one feels, I feel very sorry for lupus patients for many reasons, but one of the biggest problems is the fact that they suffer, they develop so many clinical problems, and trying to determine whether the clinical problems are directly due to activity of the disease, whether it is due to a side effect of the treatment, whether it is due to comorbidity, because approximately 30 to 40% of lupus patients are not, in a sense, content to have lupus, but they have a second, third, fourth autoimmune disease, is mighty difficult. And in fact, if you just look at the development of the damage index, for example, that predicates itself on the fact that it's not trying to attribute the cause of the damage to one particular item because it recognizes complexity. And this is slightly beside the point, but you can see how it would relate to the problems issues too. A patient might present with a cataract, for example. Now, is the cataract because the patient's mother had cataract and it's a genetic problem? Is it because the patient is on steroids? Is it because the patient also happens to be diabetic? So it's very hard in terms of attribution to know what the cause is and whether or not there's several things combining. And again, from the patient's direct point of view, consider that the patient who has a pain in their joint, in a hip joint, let's say. Now, is that because of synovitis in the hip due to active disease? Is it due to the fact they've got avascular necrosis because they've been overdosed with steroids? And how do you make that distinction? It's extremely difficult. And I'm sure we'll come to this discussion later on. I'll be very interested in what Ricard has to say. But I think from the patient's point of view, it must be very confusing when you get this whole bewildering array of problems, and yet how to be sure that it's due to active disease requiring more treatment, or actually due to damage requiring, in a sense, less treatment, or whether it's due to some comorbidity which is not being sufficiently well managed, is extremely difficult. And in a sense, as you say, Raquel, the results didn't particularly surprise me. In fact, going back to the damage index, Murray Uritz and his colleagues have shown very clearly a major cause of damage probably relates to steroids. That's a really big problem. So that's a sort of a constant and ongoing sort of debate that we have, how to minimize steroids, which are fantastic drugs in many ways. They act fast, they get in there, very quickly. They can be very, very effective, but unfortunately, all those side effects. So it's an ongoing challenge to find, from the patient's point of perspective, I think, a tool which actually reflects what the cause of a particular problem is. And as I say, from the patient's point of view, it must be very, very challenging.
Even so, we need to have these patients' reported outcomes to know how they feel. Can we optimize this? So are you using on the clinical practice any patients' reported outcomes, David?
Well, you're going to call me old-fashioned, but I don't care because I am old-fashioned. And I find the best patient-reported outcome is to actually talk to the patient, because I think you get a very good insight. The patient is trying to tell you things. And it doesn't matter whether you put a dot or a line here or you put a dot line there. Talk to the patient, get the bigger view. So for me, I understand why in the context of clinical trials, these things get introduced. But for me, it's far more important to actually to get a more global sense from the patient of the problems in relation to their disease, their treatment, their comorbidities.
Ricard, are you measuring patient-reported outcomes on your clinic? What's your strategy?
Well, I have to tell you that I fully agree with David again, because I think that the best way to have to know the feelings of the patient is just to talk and to listen to the patients. And certainly we are measuring PROS mainly because of the different research studies, especially trials. We are now preparing an app for young people that likes this kind of items to perform things, including PROS. But what I think is essential is to talk to the patient and to listen to the patient. This is the real and the best PRO that we can do in our clinical practice.
And absolutely, and I'm absolutely sure that the next presentation that we're going to discuss probably is different when you have communication that is better and talking. This other presentation, also from the COVID survey, looked at the predictors of patient-physician discordance in perceiving disease activity. And the results showed that discordance in perceiving disease activity was more prevalent in Caucasian patients that were inactive in their disease, and the patients on steroids and immunosuppressants, and whereas the patients that were off treatment were more likely to be concordant with the physician assessment. Ricard, all our practice, as you were mentioning, and David, is directed to treat patients and prevent morbidity and damage and mortality and increasing health-related quality of life. But there are huge discrepancies, not only on this survey report, but also in other reports, between what the physicians see as disease activity and what the patients look at the disease activity. What are your critical point of view, Ricard, regarding this data?
Well, certainly the main problem is what patients understand by the term activity, and in the majority of the cases, these are what we understand as type B or type 2 manifestations, which are fatigue, exam pains, brain fog, also many side effects of the drugs, especially side effects of steroids. All these manifestations that in the physicians' well characterized protocols are not considered as disease activity. For the patients, these are what they consider disease activity, and this is something that we have to take into consideration, and probably this should be also included in, for sure, in many research projects, but also in the clinical trials for the development of new drugs, because we are expecting in the new drugs that they decrease disease activity, or they prevent flares and prevent the damage, but they decrease disease activity. But patients, what expect is that this new drug that is in the market right now will decrease the fatigue, will decrease the exam pains, will decrease the brain fog. And it's a pity that in the majority of the cases, the improvement of these manifestations is very small. So maybe we have to find a way to combine these two kinds of activities, the physician's activity and the patient's concept of activity, and include this patient's concept of activity in the assessment of the different research projects, and especially in the assessment of the trials for new drugs.
David, I'm sure you do have some comments on this.
Yes, well, I really just to enhance and reiterate what Ricard said, what I was implying before, that as Ricard has said, what for the physician represents activity is not what the patient sees. The patient doesn't feel well. The patient feels fogged up. They can't think straight. The patient is fatigued. The patient couldn't take her daughter to school today because she was so exhausted, and yet all her serological markers are fine. Her arthritis is not active. Her rash is not active. I'm doing a big study at the moment with Betty Diamond in the States and some other people, looking at the very interesting question of why is it, if you ask what percentage of patients with lupus long-term go into complete remission as judged by no lupus activity, whether by SLEDA or BILAG, off all medications except for hydroxychloroquine, normal DNA binding, normal C3, our published data based on 530 odd patients was about 13-14%. 3 years full remission. It's remarkably similar to what Andrew Doria has reported from his group in Italy, in Padua, and Murray Uritz in the States. So there seem to be a group of patients who generally seem to go into seemingly full remission. And yet, if you ask those same patients, they will often tell you, yeah, I'm feeling lots of better, very much better in lots of ways, but unfortunately, I've still got my brain fog. I've still got my fatigue. Yes. These are things which have not been solved. And Ricard is absolutely right. We need to find drugs which some way, somehow will actually help those problems. And we certainly haven't solved that problem yet.
Yes, and sometimes it happens. I'm absolutely sure that it happens with you, that the patient comes and says, "How are my blood tests? Because I'm not feeling well. I'm absolutely sure I'm active." And yes, then exactly. Everything is okay. So it's frustrating both for us and for the patients to this mismatch. And it's really an unmet need in lupus. As you mentioned, we are talking about what the physicians look at disease activity. And we know there are lots of disease activity scores to measure, but there is not a perfect measure disease activity. And with these, there are two posters on the performance of the new score, the SLEDAS, compared to both SLEDAI-2K and BILAG on capturing moderate to severe and severe activity on a post-hoc analysis of MUSE, TULIP-1 and TULIP-2 and everolimus trials. Although they found similar performance, SLEDAS seem to be more sensitive than BILAG in differentiating patients with or without moderate to severe disease activity based on the health-related quality of life measures. So it was not exactly the scores of skin activity or SLE activity, but how the health-related quality of life measured also how the patients felt. David, I know you are going to tell me that BILAG is the almost perfect score to measure SLE activity. What are your thoughts on this data?
What can I say? What can I say? What I would say, though, seriously, is this. I think the BILAG and the SLEDAI systems both emerged at around the same time. That time, horrifically, for me, as I was there, is nearly 40 years ago when I was very young. It's probably still at school. And what had gone on before was truly hopeless. In the 50s and 60s, if you look it up as I did in those days, you'll find about 60 disease activity scores. They're all equally useless. So the SLEDAI, especially the SLEDAI-2K, is probably the best of what I would call a moderately bad bunch, which is a global score system. Yes, they're quick. Yes, you can get an answer relatively easily, but the problem is, and this is the main Achilles problem, they do not distinguish the patient who is somewhat better from the one who is the same from the one who is worse, because they're binary. They say you've got a problem or you haven't got a problem. But life, sadly, is not like that. And also, it misses out things. It misses out gastrointestinal disease altogether. It misses out hemolytic anemia altogether. It misses out eye disease altogether. So you could have very bad problems in those three elements, and yet your CDAI score would be 0. So that doesn't make a lot of sense. So the BILAG group, which was developed by myself, Mike Snaith, Paul Bacon, we wanted to develop a system which would capture and distinguish the patients who are better but not completely better from the ones who are the same, the ones who are worse. Our problem is it's comprehensive, and because it's comprehensive, it takes a little bit longer, especially where there's a patient with activity in several different organs or systems, though for the inactive patients, it's very fast. Mm-hmm. However, the good news, as I think you will know, is that Ed Vitale and his colleagues in Leeds had developed what they call the Easy BILAG, which is a color-coded version of BILAG, which gets you to the BILAG ABCD scores very much faster. So I think that's an advance. Now, Louis Diaz, I think, has done a great job in trying to improve the quality of the global score system with his SLE-DAS score. I think it is better. Myself, biased, because I'm working with him on a project to try to look at this. We're going to make a comparison, actually, we hope, of Easy BILAG and SLE-DAS, so I think that'll be a good thing to do. And I think, to be fair to Louis, he's done a lot of thinking about it, which I think is important. It doesn't get around the fact that it still relies on some laboratory measures, so you cannot get an SLE-DAS score the same day unless you've got your scores you're done perhaps the same day or maybe the day before. In most places, that won't be possible. You see the patient, then you do the blood test, then you get the results. So you're going to have to wait just the same. But I think it probably is a little bit more accurate. It may or may not be a little bit more sensitive. We don't know how it compares to Easy BILAG yet, but I think it is an improvement. We just need to prove that. We need to get some more external tests done by other groups, and that will come, because I think it has the capacity to be an improvement.
Ricard, have you tried to use SLEDAI on your clinical practice? Do you use SLEDAI on your clinical practice every day, or do you only use it for clinical trials?
Well, regarding SLEDAI, I have just used for testing these scores, so it's limited experience. Certainly, the final results seems that it is more sensitive than BILAG. In differentiating patients with or without moderate to severe disease activity. But we need more experience, for sure. Mm-hmm. Regarding our use of these scores in the daily clinical practice, I have to tell you that we are using SLEDAI because it's simple and quick in the clinical practice, And in the clinical trials, usually we have to use several, so we have to do a lot of work.
Yes.
But it's a good news that what David Isenberg told us, that there will be an easy BILAC soon, that probably will have the benefits of both SLEDAI and BILAC. That's good news, certainly.
Perfect. And trying to educate a little bit more and to know what are the sensation of the patients on the activity, the French Lupus Patient Association with several rheumatologists worked in a task force to develop and evaluate a self-administered questionnaire, the Lupin, to assess SLE disease activity and lupus-relevant PROs. This is available. This app would be available both on paper and as a mobile app on smartphone, so the patient can fill it while waiting for the clinic appointment or in the days before the clinical appointment. And the data was presented in Bruges was a validation study. It confirmed the role of Lupin as a good tool to assess health-related quality of life. These were only weak, and for these, there were only weak correlations between the domains of the Lupin questionnaires and the physician assessment disease activity. And this was presented in Bruges. Ricard, would you care to comment on the study findings and the potential of using it to improve the clinical practice?
Well, certainly the Lupin questionnaire looks promising results as a patient-friendly tool for assessing lupus disease activity and also for assessing lupus-relevant patients' reported outcomes. Apparently, there is a strong correlation with the classic SF-36 quality of life questionnaire. It's a questionnaire that we clinicians we physicians used to consider as probably one of the best in our field. Also, this questionnaire, the Lupin questionnaire, may provide good insights into the patient's subjective experience and well-being, and this complements the measurements of disease activity that we physicians usually consider. But obviously, we need follow-up studies. We need further studies in order to confirm these promising advances. So really, let's have a look in the future to the development of this, I think, patient-friendly tool to assess disease activity by patients themselves.
David, looking at the Lupin questionnaire by itself, do you have additional comments on this?
Well, I have a profound sense of déjà vu when I read this paper because about 25 years ago, Tom Stoll from Switzerland was doing a sabbatical in London, and he and I worked very hard together to look at the question of activity damage and patient quality of life. And we analyzed a lot of data on several hundred patients, and we show very clearly that these three kinds of tools are capturing different things. So activity is undeniably different from damage, and quality of life is undeniably different from the other two. But that said, we did find, as just the words that you've chosen, some weak correlations between activity and quality of life. So that did not surprise me at all. We'd shown it 25 years ago. So it hasn't changed actually in 25 years. From the patient's perspective, we get back to the same conversations that we were having at the beginning. I just think it remains a big challenge for the patients as well as for the doctors to try to work out what is genuinely active disease, meaning potentially correctable, as opposed to damage, which means that you can't easily correct it, and what the patient feels about it. And I learned this very simple the importance of this very simple question a long, long time ago. One of the very first things I ever did when I became a consultant rheumatologist to ask 100 successively attending lupus patients at the clinic, what's the number one thing about lupus that worries you? And I assumed it would be fear of death, fear of kidney transplant. No, fatigue. That was the number one. So that's how I learned a very important lesson right at the start.
And as you were mentioning on the very beginning of this discussion, we do need to know that when the patient is talking about feeling the disease activity, we need to be attributing to the same thing as physicians. We need to differentiate all the things that you discussed before. What is SLE activity? What are the treatments? What are the damage, the comorbid conditions? And actually, it comes to expectations and what do patients feel about what is related to what, and everyone being better educated on that, both patients and families and patients representative, and even as physicians, to what are the patient's expectations. And to educate, there's been a surge of the use of generative artificial intelligence tools in many applications and sites. And actually, there is one that is out there, at least for 14 years, the lupus100.org, that have been translated to several languages. It firstly was presented by the French group, and there are 100 questions about lupus and concerns about lupus that have answers that are available to consult both on a paper book and on the site. And one of the presented studies in Bruges, actually the results, at least for me, were unexpected, because there was a blind study between the 100 questions that were on lupus100.org answers, and those same questions were done to the ChatGPT version 4, and actually they were blindly delivered to rheumatologists and patient representative, and they found that the ChatGPT answers were considered more empathetic and more readable than those from the lupus100.org. So, David, can you please comment on this? What do you think about the artificial intelligence as an education tool for patients?
So I promise I will answer that question, but I can't resist telling you. Because it's so interesting. The SF-36 talking about numbers of questions. So where did that come from? So it came from the dear old Rand Corporation, who initially, working with some 10,000 perceived to be healthy people in the Nottingham area of England, who knew there were so many normal people there, worked out a question which had 200 questions. So they called it the SF-200. And they decided that was too many. So they went back and they had another look and they had another go, and they came out with SF-12, and they decided that was too few. And then they decided to go for somewhere in the middle, and they came out with SF-36, and that's where SF-36 comes from. So I'm always reminded of that when I think of these things. So I think, look, the truth is you cannot open a newspaper, listen to a TV program without hearing about artificial intelligence. It's sort of coming at us from all sides. And I think it's probably true that it will help us to write our questionnaires in language that's more patient-friendly. I think that's probably important. It will perhaps give us more perceptive questions as it sort of gets more and more into the details of things. So I think we cannot avoid artificial intelligence. It's already around us. It will infiltrate more and more into what we do. And I think we have to embrace it in some way. And we can't be entirely Luddite about this. We have to recognize that things are changing, and we have to try to change with it. So I'm not too surprised that it came out in some respects better than this format, which has been around for, I think you said 14 years. I think that's about my understanding too. So I think that's the way things are going. It was very interesting that it did look a little bit better. It will require a lot more work, a lot more refinement, but I think that's where it's going. That's where the future is going to be.
Ricard, do you have a view on this artificial intelligence generated education? Is it dangerous? Is it dangerous or not?
Well, can be dangerous as anything in our life can be dangerous. Our medical procedures can be also dangerous if there are side effects and we don't take care. Taking care of our patients. But I think that for sure, this is part of the future. So in addition to the human intelligence, artificial intelligence is also part of the future. And probably one thing that we can do in this Lupus 100 that I collaborated in several translations is probably to try to improve the way that these answers are written, thanks to this ChatGPT or other artificial intelligence tools. So it is fine, and there is no problem on this. And certainly we are very interested in our department, in our university. We are now leading a master's program on artificial intelligence in medicine, with a module on autoimmune diseases in the University of Barcelona that will be run by one of my colleagues, Manuel Ramos Casals. So I am sure that this is part of the future. Also, human intelligence will be the other part of the future, I hope.
Let's change a little bit the subject for now. And as it could be expected, lupus nephritis was one of the main topics in Bruges. And some studies were presented. We're going to select a few of them. And of course, you can comment on others that you want to. And one that captured our attention was that a recent multicentric observational study in Greece, 135 patients with lupus nephritis were assessed, and they were primarily treated with cyclophosphamide or MMF. And they then went to see the outcome according to the EULAR at the renal response rates. And at 12 months, 84.4% achieved the renal response rates. Although it's good, it highlights that 15.6% of the patients didn't achieve response. Ricard, given these findings, what more do you think can be done to improve long-term outcomes in patients receiving conventional immunosuppressive therapy for lupus nephritis?
Well, first of all, I have to tell you that I am quite happy to see these results with the conventional immunosuppressive therapy, because it also includes the Eurolupus regime that was deeply involved in the development of this regime. And we certainly believe that it is a good therapy for the majority of the patients. If it is 84 or if it is 76, probably this will depend on the centers. And also, I think that it's important, answering your question, how to improve the results of the conventional immunosuppressive therapy is to also to improve the nephroprotection measures and the collaboration with the nephrologist to do nephrologist and autoimmunologist joint clinics for lupus nephritis. This is probably something that we can do better. In most centers, probably we autoimmunologists, we probably think more on the new immunosuppressive drug, the new biological therapy. But in addition to this, there are nephroprotective drugs that we have to use. And probably this will also improve the effect of this conventional immunosuppressive therapy. But for sure, there will be patients that require let's say, innovative therapies, new biological therapies, or the new anticalcineurin therapies. So certainly we must enlarge the armamentarium of therapies, immunosuppressive, biological therapies for lupus nephritis, for sure.
David, from the data presented in Bruges, do you have any additional comment on where?
Yes, I do. I found those results rather surprising.
Okay.
About 15 years ago, there was a very big trial called the Cervera trial, comparing the use of mycophenolate versus cyclophosphamide in two ways. First of all, to make a direct comparison between mycophenolate and cyclophosphamide in terms of getting patients into renal remission. Secondly, having got them into renal remission, then to try and determine whether mycophenolate was better than azathioprine at keeping them in renal remission. And if you look at that data, it's much more disappointing. There, the numbers of patients who got into renal remission was about, in my mind, it's 53%, but it's certainly around just above 50%. And yet this study from Greece, using broadly similar approach, claims much, much better results, like 85%. So I found that a little bit surprising, and I didn't have a chance to ask them, but I will when I see my colleagues from Greece, why they think they did so much better. Now, there may be perfectly valid reasons, but that result was a surprise to me because it was better than I thought it was going to be.
And I know it's good for lupus nephritis. These results are very good. And the thing is, those 15% of the patients that didn't achieve remission, how can we do better from the beginning, not knowing who is going to achieve remission or not, since not being in remission means loss of nephrons. And taking this in account, one of the other presentations and study that were presented was an analysis of propensity matched data from the Aurora trials and the ELM trials, comparing that. And it seemed like they identified the safety and efficacy of voclosporin-based triple therapy was superior to, and the reducing protein was superior on the voclosporin-based triple therapy compared to IV cyclophosphamide or MMF. And do you think these data and even the BLISS-LN data are appropriate for us to use from the beginning to capture the more quantity of patients going in remission?
So the results of voclosporin, of course, are exciting in terms of trying to get better control faster. The problem, of course, is the cost. So the United States, voclosporin costs in the region of $90,000 per patient per year. It's very interesting to me that the company who make it did go to NICE, unlike AstraZeneca, who have not gone to NICE to ask about getting anifrolumab approved by NICE, because AstraZeneca are worried that they will be asked to cut the price. I don't know the precise amount, but I can tell you in approximate terms, the cost of voclosporin in the UK is probably about a sixth the cost in the United States. I don't know what it costs in Spain, but I'm going to hear from Ricard. Clearly, my colleagues in nephrology are beginning to try it, although I think many of them also, perhaps we'll come to this, are continue to be impressed by tacrolimus, or as the nephrologists call it, tacrolimus. So that's an awful lot cheaper, I have to say. So at the moment, we're just beginning to introduce voclosporin into the treatment of some of our patients, trying to get better control, protein down faster. But to what extent it will replace the use of tacrolimus, to what extent it will be affordable internationally, is, I think, very uncertain at the moment. It's a good tool to have in your toolkit, as it were, but how widely it's going to be used, that remains to be seen, I think.
Ricard, do you already have access to voclosporin in Spain?
Just approved. Just 1 month ago, it was approved. It was also approved in our hospital. So we have just one patient treated with voclosporin. And the good news is something in relation to what David mentioned, the cost of the treatment. And the good news in Spain is that they put at a similar, even a slightly lower cost than belimumab. So the competitor.
I wonder why.
Yes, exactly. That's something that was amazing for us, because we really knew the price in the States, Germany also, but they did a very good job. I think that the cost, the price of the drug is essential in order to implement the use of voclosporin. That certainly looks a very good drug. It has a quick effect, decreases proteinuria, and if the cost is the problem, apparently in Spain we will have a similar price than the direct competitor.
No, it's good news. It's good news.
Yes.
Let's look if they're going to do it in all the Iberic Peninsula. So we're waiting for that also in Portugal. And actually,
I was talking today with people. Actually, I had lunch with people from that company, and I hope that they will go to Portugal very soon. So hopefully, also in Portugal, you will have this good news soon.
The thing is, we do believe voclosporin is going to be an excellent drug for lupus nephritis, and the clinical trials were very good design. The design of the clinical trials are very good for voclosporin, which never happened for tacrolimus in lupus nephritis. And actually, one of the presented study was in Bruges was a retrospective study on long-term renal and cardiovascular risks of tacrolimus in lupus nephritis, and it was conducted in Leiden. There are 223 patients that were enrolled in this study. Part of them had been on tacrolimus, and those that were not on tacrolimus were the control group. And actually, 10 years risk of coronary heart disease was lower in the tacrolimus group. So we do know that tacrolimus is effective as a calcineurin inhibitor with a good safety profile, but it didn't show on the clinical trials because they were not designed for that. So let's see if in countries that voclosporin is not available, if tacrolimus could have also a good result. So, but it was very good news to know that voclosporin is going to Portugal also, and coming to European countries with a low price. It's a very, very good news. And from the real world data, we do now have belimumab available for treating lupus for 12 or 13 years. And there are several real-world data that have been published and presented. And in Bruges, data from the OBSERVE study showed that 90% of the patients who received at least 80 infusions of IV belimumab achieved a steroid reduction to less than 5 milligrams a day within 2 years of the starting treatment. And low disease activity and remission rates also increased over time. Although from anifrolumab, the real-world data was less. Of course, it's available in some countries, not available yet. As David mentioned, in the UK, it's not available. And in Portugal, only for a few months, in Spain, a little bit more. The availability was most for the European countries. There were 3 real-world presentations in Bruges. One of refractory skin disease, and the 2 other for 9 patients with global SLE refractory patients. So we do have available real-world data. And now I'm going to do a little bit of question to mimic what happened on the final debate. The final debate of the European Lupus Congress in Bruges had Michel Petri on one side and David Isenberg standing for the opposite points of view of a minority of patients or a majority of patients with SLE will need a biologic. David, can you please comment on the results of the debate?
Obviously, my argument was much stronger. I mean, that goes without saying. But I thought it was a good debate, very lively, and I enjoyed it, I have to say. And for me, it was unusual because in the past, I've often got involved in these debates and I've been put onto the side that I don't actually believe it. So it's quite intellectually challenging to sort of go 360 degrees. This was exemplified for me some years ago when I debated the use of Benlysta, ironically, with Beverly Hahn. I'd just gone to NICE 4 times to beg for it to be used in the UK. And in the debate, I had to speak against the use of Benlysta. So that was a bit of a challenge. But this I actually believe in. And the data that I showed was that, in fact, if you look at long-term, in particular, lupus nephritis, and I showed the data from our own group, but also backed up by data from big studies in the States, in particular from Minnesota, the outlook for lupus patients with conventional drugs in terms of benefit, it's hardly changed in 30 years. And Eric Morand, actually, in a very nice review of lupus, which he published in the British Medical Journal, concludes that conventional drugs we've got as good as we can get them now. We're not going to see any major changes. If we want to improve long-term the outcome for our patients, I think we have to go to new methods, and these includes perhaps the combination of biologic drugs. Been some interesting studies which you might want to touch on in combining rituximab and Benlysta, for example. CAR T cells will probably say a few words about. So I think that for me, the future is beautiful, but the future is biologic. That's the way I would sum it up.
Ricard, you were not involved in the discussion. You were listening as I was there. Do you have a comment on the final debate?
Well, I don't know if the exact percentage will be a majority, so more than 50%, or a minority, less than 50%. But I fully agree that a large amount of patients will benefit of innovative therapies in the future.
David, I think that it was unequal here that you were presenting our point of view. Of course, that in the last Congress, all the last Congress where lupus was debated, there was a major issue there: CAR T cell therapy, which is a novel immunotherapy that engineers T cell to target specific antigens. It is promising, and it has been used for treating B-cell malignancies and other cancers with amazing results. And there are also studies suggesting that CAR T cell therapy targeting CD19, a protein expressed in B cells, may also be effective in treating lupus, particularly in patients with refractory disease and refractory lupus nephritis. David, 2 additional studies were presented in Bruges. Do you want to comment them?
Well, yeah, very quickly to give the background. So the notion of B-cell depletion being a useful tool to treat patients with autoimmune rheumatic disease, that was the idea of a colleague of mine called Joe Edwards, who developed it for rheumatoid. And he and I had many discussions 20 or 25 years ago now, and my colleagues and I introduced it for lupus. The problem is the Achilles heels are, number one, 20% of rituximab is mouse protein, so approximately 20% of lupus patients in the end, if you treat them repeatedly, will get an allergic response. You can show that B-cell depletion works, but you can't use the treatment anymore, which is very frustrating. And number two, rituximab will only go after the B cells, the CD19 positive B cells in the circulation. And that's pretty key. And George Shett is a lovely guy, and I've had a chance to talk to him 2 or 3 times. And he always says to me, really, CAR T-cell therapy is expensive B-cell depletion, because what you're doing is, as you know, you're genetically modifying T-cells to go after CD19 positive B-cells in the circulation or in the tissues, and that's the critical difference. And he thinks that it's the capacity to get rid of those B-cells carrying the CD19 marker in the tissues which makes all the difference. Now, he's treated, I think, and published on 8 patients with lupus, I think 3 with myositis, 4 with scleroderma, and you're beginning to see now 1 or 2 case histories coming through from other groups, and we, and I'm sure Ricard as well, are pushing very hard to develop this skill in our own center. We have a big cancer center. They've been using CAR T-cell therapies for 8 or 9 years now, so we already nominated the first patient we're going to treat in the next few weeks' time, we hope. So very, very, very exciting, because what's amazing, and it really is amazing, is that within 3 months, the patients that George Shett was treating were off all lupus treatments. The DNA binding, which had been in the thousands, is back to normal. C3 is normalized. And what you seem to get back is a normal immune system, in the sense that these patients continue to respond to tetanus toxoid, to measles. They keep the standard protective responses, but the autoimmune B cells don't seem to reemerge, and that's staggering. I mean, that really is staggering, as indeed is the price, which is also staggering. But that's another question. So I think it's remarkable. I think clearly it's not going to be available for more than a handful of patients. But if George Shett is right, eventually it will become more widespread, more widely used, and could be a major, major advance for us, which would be marvelous.
Thank you. Ricard, at this point, when you see this kind of treatment that almost cures lupus, although so expensive and not completely exempt of adverse effects, can you remember patients that you had in your career seeing lupus patients in whom you would have proposed CAR T-cell therapy if available back then?
Well, actually, in our hospital, we have so far the only academic CAR T therapy that has been approved by the EMA, by the European Medicines Agency, and they have widely used in malignant hematological conditions, and they are pushing me to also to give in a compassionate use to one of our patients. We have presented this in the board to select the patients, a couple of patients, but finally it was not decided to continue. Actually, the first patient with autoimmune diseases that was approved was yesterday, but it was a patient with systemic sclerosis. So yes. I will see if it works, because we have great expectations. As with voclosporin, the good news is that as this is an academic CAR T produced by the immunology department in our hospital, is much less cheaper, much less expensive than the one by the drug companies.
Perfect. And we are here talking and excitingly talking about new treatment, new expectations. And just to finish our discussion, I would like to remember one of the themes in Bruges. Equitable health outcomes in lupus are very important, and there are some additional data presenting also from COVID survey, but we are aware of that, highlighting the significant regional treatment differences from globally and within continents when evaluating for the Human Development Index. And this poster that highlighted this, the availability of different drugs throughout the world, countries that do not have any biologic at all, countries that do not have MMF even. So this inequality, Ricard, after what we have been discussing for the past 40 minutes and the final debate of the Congress, can you please comment on these regional treatment differences?
I fully agree. This is a great challenge for us physicians to try to decrease these regional differences. For instance, I have strong relations with many Latin American countries where I can explain many things that we do in Europe that for them is just science fiction. So this is something that we have to change for sure. And probably one of the things is to decrease the price. And this is possible, certainly. As we have mentioned before in these two examples, voclosporin and CAR T cells, it is possible to decrease the cost of the drugs. So this is a great challenge that we have to face in the next few years.
David, comments?
So many years ago, I was invited to go to the 3rd Pan-African Congress of Rheumatology in South Africa, in Cape Town. And I thought the best talk was given there by an ethicist. It was around the time that the biologic drugs were coming out and sort of coming everywhere, at least in Europe. And she said to us at the Congress, you guys have to understand that in Africa at the moment, there are 10 major wars going on. The prospect of these incredibly expensive drugs coming to any of these countries in Africa is zero and will be for the foreseeable future. So yeah, it's the price of the drugs, that's true, but it's also the geopolitics of the situation. If you've got a country which is at war, I'm afraid they're not going to be prescribing Benlysta very frequently to the lupus patients. So these are the additional issues which we face. And clearly in our day-to-day practice, it's hard enough to sort of get by trying to sort of cope with all the patients that we have and all the administration and everything else. And we kind of forget about these bigger issues, but they are definitely out there. And we don't have quick solutions to these problems, but that doesn't mean we shouldn't be trying to do something about them.
Thank you so much. Ricard, do you have any final comments on the European Congress?
Just to repeat what we said at the beginning, this was an excellent meeting point for all lupologists. And this was mainly thanks to Fred and Natalie, who did an excellent work.
David, any additional comments?
Yes, I absolutely endorse that. And also to say how great it was to be in Bruges, where every other shop sold chocolate. It was wonderful.
Can I add something on the Congress? I think that the opening ceremony, having Fred
Oh, yes, I forgot that. You're right. Yes.
playing the
Fantastic.
piano
Yes,
and his
yes,
wife
true,
singing was amazing.
Yeah.
And even in the end of the Congress, Ronald von Haven was playing the piano on
Yes.
the entry of the
Yes,
venue,
that's
and
true.
it was an additional musical there. So even the non-scientific things were
Great.
very touching.
Yeah.
It was really great to be there. David and Ricard, thank you so much for joining me today and sharing your insights. To our listeners, we hope these discussions have helped you gain more of an understanding of the latest developments in lupus. Please download the Lupus Academy's SLE Road 2024 highlights report from our website. A link can be found in the show notes. Thank you so much for listening. We hope you enjoyed this podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world.